Welcome to today's webinar entitled The 5 Most Common Myths of Neck and Back Pain. I'm Jeff Walker, and now it's my pleasure to introduce Dr. Ben Benjamin. Dr. Benjamin holds a Ph.D. in sports medicine and education, is a well-known, respected author, educator, and practitioner in the massage and bodywork field. He's an author of these 4 books, widely used in the field, as well as his popular regular column in several therapy publications since 1986. Dr. Benjamin founded his school, the Muscular Therapy Institute, in 1974 and has been in private practice for more than 45 years. He travels throughout internationally teaching orthopedic massage as well as Aaron Mattis's active isolated stretching. He's also created a series of DVD programs on the assessment and treatment of the lower back, the neck, the knee, and various common injuries. So now it's my pleasure to hand you over to Dr. Benjamin.
Thank you, Jeff, and thank you all for attending this webinar. I'm looking forward to coming to Sydney in March to teach, and this just gives you a chance to get to know me a little bit and see if you want to come. So here's some things to keep in mind as we do this particular webinar. How much information does an active movement that's an assessment test give you? Sciatica is caused by pressure on what structure or structures? Is whiplash a specific injury? Which structures in the neck cause the most cases of chronic pain? And what's the precise definition of referred pain? So if you know those things, you're going to get a little more information about them, and if you don't know them, you'll get some new information. And for those of you who came to the last webinar, just the first few slides will be the same, and then I'm going to do some new things, and then some similar things toward the end. So as Mark Twain famously observed to a man who has a hammer, everything looks like a nail. So in the context of health concerns, this means that the tools most easily available to us, including our theories, our assumptions, our testing procedures, and technical skills, they have a tremendous impact on the type of care that we choose to provide for people. Now, healthcare professionals in different fields offer dramatically different assessments and treatments for the same condition. For instance, in the cases of pain and injury, we would expect chiropractors to address spinal misalignments, acupuncturists to emphasize the flow of energy or qi, and surgeons to consider surgical options. And within the field of massage therapy and bodywork, the focus has typically been on the muscles. Over the past few decades, many health professionals have begun seeking therapeutic alternatives outside their traditional modes of practice. Physicians are working in collaboration with chiropractors and referring more patients to massage therapists. Chiropractors are broadening their areas of expertise, learning how to work with a variety of soft tissue injuries. I know many surgeons who work in hospitals with massage therapists, at least in the United States. I don't know if that's true in Australia or not. Massage therapists, too, have been integrating new knowledge and skills into their work by studying other bodywork modalities, as well as personal training and fitness. It's a really excellent practice to, for instance, go to somebody's house or have them come to your office and work them in a fitness program, teach them various exercise programs that they could do at home, and then to give them a massage therapy session. Now, some of these changes, including an increasing reliance on the principles of orthopedic massage, have allowed practitioners to dramatically increase their effectiveness. So orthopedic massage refers to the precise techniques for assessing, understanding, and treating musculoskeletal pain and injury. Using orthopedic testing procedures, we can more clearly identify what structure or structures have been injured so that the treatment can be targeted to those particular tissues. We can also determine what treatment methods will be most effective for each individual depending on what's going on for them. In addition to hands-on therapy, we may perform specific stretches on the client or recommend various exercises for them to help them get better more quickly. Now, my study of orthopedic medicine began over 30 years ago and really transformed my practice and my teaching, leading to incredibly greater success in the treatment process. I remember I did a lot of guessing before I learned all this stuff. But when you have this knowledge, it's kind of like being a detective with no guns or anything, but you really can target and figure out exactly what's going on. And it's very exciting, at least it was for me. In this webinar, I'll use the principles of orthopedic medicine and orthopedic massage to correct 5 misconceptions that are prevalent in our profession. Now, I've studied with Dr. James Syriacs over here on the left and Dr. Milne Ongley on the right, starting about 30 years ago. Dr. Syriacs was from London and Dr. Ongley is from New Zealand. So misconception number 1, pain caused by active movements gives you a good indication of what structure is injured. So if you ask a person to lift their arm or do a particular action, this gives you a lot of information according to this myth. Now, orthopedic massage differentiates between 3 main types of movement: resisted, passive, and active. For determining the location of an injury, tests of active movements provide actually the least reliable and the least important information. Resisted tests, which are isometric contractions against resistance, test for injury to the structures that initiate the movement. For example, the muscles and the tendons. So here I'm doing a test for the psoas muscle, and I'm going to allow the thigh to come just above 90 degrees where the psoas really engages. So here I'm testing the muscles and the tendons. I might be testing for pain and also maybe testing for weakness. All of a sudden, if I could just push that leg down, which I shouldn't be able to do, I'll be testing for pressure on a nerve that may be causing that weakness. Now, if the person is weak, first thing I would do would be check the other side, because they may be weak on both sides. It just means they don't exercise, they're not very weak at all, they're not very strong at all. But in most cases, if it's very weak, it means there's something terribly wrong. Now, passive tests, in which the client behaves like a rag doll, they do nothing, they just go limp, and they're moved by the therapist. Test for injury to structures that do not initiate movements. So for example, here I'm doing passive adduction, horizontal adduction, and the person I'm trying to see if the person can move through space without pain. And in this case, I'm squeezing on several things. I'm testing the subscapularis, which I'm compressing against the coracoid process. I'm stretching the infraspinatus in the back of the joint here, and I'm also testing the bursar, the acromioclavicular joint, the acromioclavicular ligaments, testing many different things. And the thing they have in common is they don't initiate movement, the passive structures, the ligaments, the joints. And with the passive test, I'm also getting some information about the tendons and the muscles, but I'm not getting the information that it's that muscle. If I wanted to figure out if it was the subscapularis, I would have the person in another position. I'd have them do resisted medial rotation. This will only give me some auxiliary information, but it does give me reliable information. The passive tests are very useful. However, the active tests, the person moves his or her own body through space, and they're also using their muscles. So this simultaneously tests the structures that initiate movement, meaning the muscles and tendons, and those that do not. If, for instance, I just lifted my arm above my head myself, or I reached behind myself. And that makes it very difficult to tease out what is actually causing the pain. So in summary, active tests give you an idea of the territory, but not the specifics. For instance, if I ask a client to lift their arm overhead and they can't do it, or they do it and struggle and make faces while they're doing it, I've gained some important information. They can't lift their arm without pain. So I'm going to be very careful when I test them, particularly if I have them bring their arm up. However, I don't know why or which structures are involved. Resisted and passive testing gives you that more full information. Here on the lower right, I'm testing for the supraspinatus tendon injury over here, and back over here I'm doing a passive test, passive medial rotation, checking the range, and sometimes for pain. That gives me other types of information. But here we're not going to deal with that, those injuries at this moment. Maybe if you like when I come down, I'll come back and do the shoulder, and we'll look at this. So let's look at misconception number 2. What is referred to as sciatica or sciatic pain is generally caused by pressure on the sciatic nerve. It's a common misconception that sciatica is a precise diagnosis. It's often used to mean the sciatic nerve, one of its branches, is impinged upon or pinched by either a disc or a muscle, sending pain down the leg to the foot. Now, in truth, that's not what it means. It's a very loosely used term that means a pain going down the leg. It just means a pain going down the leg, and it doesn't tell you what that pain is. Now, more precisely, the definition of sciatica is a pain originating in the low back, referring pain into the buttock, down the thigh and lower leg, or all the way into the foot. Now, this type of pain can be caused by many, many different injuries. It may be caused by a muscle injury in the gluteus, in the buttock, the gluteus medius or maximus. Here, the gluteus medius is the most common. It refers pain down to the lower leg, actually. A ligament in the sacrum, one of these ligaments here, can send pain down the leg. A disc, a pressure on a nerve root, an impingement of a nerve root that's compressing, most likely compressing only one nerve and not the entire sciatic nerve. Or what we call spinal stenosis, which is the squeezing of the nerve because the bone develops various degenerations and the space gets smaller with little bone fragments that are growing into the disc, the space where the nerve comes through. Actually, the sciatic nerve consists of 5 separate nerves: L3, L4, L5, L6, not L6, S1 and S2. So all of those nerves combined make up the sciatic nerve. Now, generally, they're never compressed all at once. They may be compressed, one of them, like L4 or L5 or S1, are the general ones that are affected. However, according to orthopedic physicians and neurologists that I've worked with, only 3 to 5% of all the cases of what we call, quote, sciatica are caused by discs pressing on nerve. So what's causing the other, 95 to 97% of the cases? Let's get that slide. So more often, pain down the leg is caused by injuries to other structures, such as the sacroiliac ligaments that we showed you before, the sacrotuberous ligament, which is this one that goes way down here to the ischial tuberosity, as right as the edge of the sacrum, the gluteus medius muscle, which we showed you before, and the iliolumbar ligament, this one right here. Iliolumbar ligament is a very frequent cause of pain that goes down the leg, usually goes down just the thigh. And of course, the fascia that's covering all these ligaments will also cause pain down the leg, as well as the hip joint. A problem that's inside of the hip joint will cause pain down the inner thigh. So I can't tell you how many times in my career that I've seen someone who's been told that they have sciatica, meaning a slip disc or a compression of the nerve. And if that were true, the treatment that I recommend would rarely ever work. You can't massage a disc off of a nerve root. And you can't do an exercise that sucks the disc back into place. Once it's extruded from its casing, it's not going anywhere unless you wait 12 to 18 months while it dries up and drops away, or you have surgery to remove it. Now, I'm not talking about a slight bulge, but a full-blown extruded disc that's pushing out of its casing, and it's causing very, very severe pain. Now, the reason so many people get better from back pain with leg pain is that sciatica is usually caused by an injury to the ligaments, the muscles, the fascia, and can be effectively treated by hands-on methods. And I remember when I started, I'd just do everything I could think of, and the person would get better. But later I learned they got better by accident because I happened to be on the right place some of the time. And when I learned the things I learned from Dr. Syriacs and Dr. Ongley, my efficiency and my effectiveness went way up because now I knew what I was doing. Now here you see me working on the sacroiliac ligaments after I've worked through the thoracolumbar fascia. So let's go on to misconception number 3. Once ligaments have become weak or stretched and distended, they cannot be re-strengthened or tightened up again. Now, this is something that I believed for a long time because I hadn't learned about what you can do when you have loose ligaments.
Hello,
loose
Ben,
ligaments
if
cause
I could
a
just
lot
interrupt.
Huh? Yes?
Sorry, Ben, we've just lost the screen there.
You've lost the screen.
Yeah, there's a screen, but it's just showing the front page, the 5 common myths,
Okay.
like the title
better?
page.
Does that come back now?
Yes.
Okay, great. Well, thank you. I don't know how that happened.
Thank you, everyone.
But between Boston and Australia, was a little glitch there.
Yes. All right. Thank you.
Okay. We said this concept that the ligaments are, when they become really weak or stretched, you can't really retighten them or re-strengthen them. And that's not really correct. Ligaments are the anatomical structures that hold our bones together. And without them, we would collapse onto the floor and never be able to stand up again. And to function well, we want our ligaments to be tight and strong, holding the bones in place with only a slight amount of movement or play in them. If we don't use our bodies, they atrophy and they weaken. So anyone who spent a few weeks in bed, due to an illness or other condition, knows that muscle atrophy sets in very, very quickly. It's even hard to walk without shaking when you finally get out of bed and begin to walk around again. And there's a saying that says, if you don't use it, you lose it. And this is quite true. Now, this is true not only of the muscles, but also of other structures in the body that are dependent on movement and stress to maintain their integrity. When the astronauts went up into space for any extended period of time, they began to notice that they suffered from bone loss because no stress was being placed on their bones. And they quickly corrected that and had them doing lots of exercises and doing all sorts of things to stress their bones, as well as their muscles, the ligaments, etc. The same thing is, of course, true of ligaments and tendons. Ligaments in particular weaken as a result of diminished use. For example, if someone suffers from an injury and restricts their movement for months at a time, the internal structure of the ligament weakens and becomes very, very vulnerable to injury. For example, if the low back becomes injured and we restrict the use of our back by not lifting anything, not bending forward, not twisting, and so forth, the ligaments weaken and become vulnerable over time, and more of them join the ranks of the injured tissue. So how do you strengthen a weakened ligament? If the weakness is mild and developed over a short period of time, then just returning to normal activity and to exercise after you recover from an injury or illness is usually enough. But if the disuse continues over a long period of time, say several months or longer, then some other method, might be needed. Now, I discovered that a side effect of Aaron Mattis's active isolated stretching is gradually strengthening the ligaments without re-injury. And here I'm demonstrating some of the motions that stress the low back, particularly the ligaments and the muscles in the pelvic region. And I discovered that a side effect of his work was that he didn't actually say that it strengthens ligaments. He was just going for the flexibility of the muscles and the fascia. But I noticed that it really strengthened the ligaments as it places repeated mild tension through ligaments hundreds and hundreds of times in one session. Now, if you only put a ligament under tension for a few seconds at a time, you strengthen it. If you stretch for longer periods of time, then the likelihood is that you will distend and permanently stretch the ligaments, which is not desirable. That's not what you want to do. There are hundreds of different ways to do this, several hundred, and I'm just showing a few over here. Now, the second issue is loose ligaments, and this is not so easy to affect with any hands-on method. When a ligament has been permanently stretched, either by an accident or by slow deterioration by the formation of adhesive scar tissue, or if the person is genetically over-flexible, that is, that they were born with ligaments that were just too long for their body, then hands-on work, to my knowledge, can really do nothing to shorten them. Somebody that is quite young and they can put like this woman here, they can bend their back, they can put their foot over their head, that sort of thing. We often call them double jointed, but that's not what they are. They just have very loose ligaments. So what I discovered, many, many years ago, about 30 years ago, was proliferant injection therapy was very effective in tightening, shortening, and strengthening ligaments all at the same time. Now, a proliferant is injected, and what it does is it irritates and stimulates the ligament or the tendon, whatever tissue you're injecting, causing them to grow new like tissue that strengthens the ligaments. The first part of the injection breaks up the adhesive scar tissue, and the second part proliferates actual new tissue. Now, this method of treatment was very primitively experimented with in the 1800s, and then further developed in the 1940s by a physician in the United States in Ohio named George Hackett. Now, Hackett used psyllium seed oil as the major ingredient in his proliferant. Now, although these injections were really successful in tightening the ligaments and helping people, the psyllium seed oil caused a great deal of pain right after the injection and during the healing process. And as a result, few people really wanted to use that treatment because it was so sore. Now, in the mid-1950s, a physician named Milne Ongley, that I mentioned before, from New Zealand, began developing solutions that caused the proliferation of new tissue but was not painful for the client. He spent many, many years working to improve the proliferant solution and the technique of injection. And the solution is often referred to as the Ongley solution and contains these four elements: dextrose, which is a sugar, which irritates the ligament or tendon and causes it to trick the brain and regrow. The glycerin is to control blood clotting because a little tiny bit of bleeding. Phenol is for sterilization, and xylocaine is to numb the area so that you know you got the right place. When someone is injected with a proliferant into, let's say, their low back and they've had pain for 5 years, as soon as you inject them, their pain diminishes by about 90% because they're just making it numb. It's like the stuff that the dentist puts in your mouth to do the dentistry on your teeth and not hurt you. So it's a way to check that you actually got into the right place. Now, about 1,000 physicians have learned the use of proliferants, and dextrose is the primary active substance, and it irritates the tissue, and it causes like a mini trauma to the tissue. And whichever structure is injected slowly proliferates new tissue over the next few months, actually, with the most accelerated healing occurring in the first 3 to 7 days following the treatment. The ligaments tighten, and they actually thicken and increase in strength by 30 to 40%. And in my opinion, this is one of the most important discoveries in soft tissue medicine and treatment in the 20th century. And it's very unfortunate that so few physicians are very skilled at this procedure. Now, although there are 1,000 physicians that do it, most of them are not very skilled. This is not taught in a medical school. It's just taught here and there. But it's a magnificent treatment, and hopefully it will gain more physicians doing it and gain in popularity as time goes on. Now, Dr. Ongley spent a little bit of time in Australia doing it on his way to England, and hopefully that will gain in popularity throughout the world. So let's go on to misconception number 4. Whiplash is a precisely defined injury in the neck. Now, although many people refer to whiplash as a specific injury, it is not a precise injury. It's an action. Whiplash is defined as a sudden physical action of acceleration, deceleration force, which causes damage to structures in the neck. Many, many, many structures. Now, this can include damage to the intervertebral discs, nerves, ligaments, muscles, zygapophyseal joints, which are the facet joints, the fascia, and so forth. And research using high-speed cameras shows the mechanism of the injury is generally rapid hyperextension of the neck, rapidly followed by hyperflexion of the neck. As you see in this picture here, it goes through a very painful movement, tearing up all sorts of things. This motion causes multiple tissue damage in the muscles, ligaments, and fascia generally, setting the body up for the development of chronic adhesive scar tissue. This is tissue that heals poorly, that will tear and tear and tear again and again and again. Now, whiplash usually occurs in a rear-end collision. You're sitting in your car, and somebody smashes into you at a red light or a stop sign, and the motion is generally posterior to anterior, or anterior to posterior. But it can also occur laterally from side to side, from a side impact in an accident. And when this occurs, the pain and damage is generally to the structures on the side of the neck rather than the front and the back, resulting primarily in pain on one side of your neck or both sides of your neck. Now, it could also occur from a head-on collision, but it doesn't have to occur in a car. Actually, whiplash was first noticed in train accidents almost a century ago, and it was called railway spine. Whiplash can also occur by colliding with another person. Now, often this happens during sports, a sports event like football or basketball or soccer. And whiplash will often be accompanied by a concussion as well, when the head snaps back or forward and hits something. It could hit the windshield wipe. The windshield can also hit the back of your seat. And this may result in many different symptoms, including a terrible, nasty headache that can go on for weeks or months, or I've seen people where it went on for years. In many cases of whiplash accidents, people recover quickly without any chronic symptoms at all, but other people continue to experience painful symptoms for years and years after the injury. Now, I remember a very high-functioning athletic woman I saw 3 years after being rear-ended at a stoplight. She had daily headaches, mostly in the occipital region, along with pain in her right scapula, her arm, and occasional bouts of vertigo, sort of dizziness, and she was nauseous much of the time. And right after the accident, she only had a headache. And after a few weeks, she had neck and arm pain, and by the end of the second week, the other symptoms followed and never abated. So all this is to say that whiplash is not a specific injury. It's an action that causes multiple injuries. So let's look at the structures that can be affected when a whiplash accident occurs. First, let's consider the muscles that are usually affected. The occipital muscles of the neck, both the deep ones, which are deep underneath, and the superficial occipital muscles are often injured. The splenius capitis, back over here, the splenius capitis and cervicis muscles at the back of the neck as well, and also the sternocleidomastoid muscles that rotate the head. You see it over here, part of it's cut. And also the scalene muscles that are on the sides of the neck, in the middle and anterior and posterior. Those are often affected and usually heal pretty quickly because, as you see here, the muscles are highly vascularized. They're red because they're filled with blood, but the ligaments are not. The ligaments in the cervical region are, a lot of them are affected. The supraspinous ligaments in the neck, right here in the back, which are commingled with the ligamentum nuchae. The interspinous ligaments, which are underneath these ligaments, which are very deep. Also the transverse ligaments, which are the ones on the side holding your facet joints together. And also these, holding these spinous, the intertransverse processes together, which are supporting the facet joints. The fascia surrounding and covering all of these ligaments and muscles are also affected. And then, of course, there are the discs that can be damaged and displaced so that they compress one or more of the nerves in the neck, but this is generally not the case. Generally, C5 and C6 is affected if it's a nerve root problem because there's more movement at C5, C6 than at any other place in the neck. But it can be any of the other nerves, but again, it's generally not the nerves that get affected in all of these injuries. And usually it is the muscles and the ligaments that get traumatized. The muscles usually heal over a period of a few weeks, but then the ligaments set in and the person has pain for a long, long, long time. And the blood circulation, of course, makes the muscles get better more quickly, and what's left behind are the ligaments that are not very vascularized at all. So there's also trauma to the brain through a concussion, and this can take quite a while to resolve. Now, in the example I gave you before of the young athletic woman that I saw 3 years after the accident, the anterior neck pain was from the muscles, and they had healed quite quickly. She said that part of it went away really fast. And the ongoing neck and scapular pain comes from ligaments and scar tissue, which generally begins to appear a week or two after an accident, any kind of an accident. The damage from the concussion can last for a few weeks or it can go on for years if not properly treated. And in this case, I saw her and found that her cranial rhythm was extremely weak and uneven from right to left. Her supraspinous ligaments at the back of her cervical spine were severely damaged from C7 through C5, as well as those on the occipital protuberance. There's a little ligament. If you put your hand on the back of your head and you find your occipital protuberance, that little bump at the back of your skull, there's a little ligament right under that that many people don't even know exists that cause a lot of pain. And then the C1, C2, and C3 ligaments were also affected there. Now, these upper ligaments refer pain to the back of the head, which are often experienced as a headache. Now, the lower ligaments can cause neck and arm pain. And I also found that her intertransverse ligaments were damaged at C5, C6, and C7, causing pain in the lateral neck and down the medial border of the scapula. That's where these ligaments refer pain. Now, in addition to the fascial covering of these ligaments showed fascial distortion and pain-producing scar tissue, and you can just easily test for that, and I'll be showing you that when I come down to teach the workshop on the neck. Now, the concussion was not something that I could deal with, so I referred her to a cranial osteopath who successfully treated her cranium and restored her weakened and distorted cranial rhythm. And after 3 or 4 months of combined treatment of the fascia, the ligaments, and the cranium, this client gained relief and began to get her life back again. She couldn't believe it, that she was actually better after 3 years, but no one had ever noticed those ligament problems, and when you don't get them treated, your pain goes on and on and on. And the upper ligaments can give you some headache, and the lower ligaments gives you neck pain, and also pain in your upper back, in this case in her scapular region. So let's move on to our 5th and final misconception. Working at the site of the pain yields the best results. Now, one would think that's true, but it's not true. The location of the client's pain is really, really misleading. And in many cases, pain is referred from the source of the injury to another part of the body. Only certain areas of the body refer pain, and these include the shoulders, the neck, the thorax, the low back, the sacrum, and the hip joints. Some of the areas of the body do not refer pain, and primarily these are the distal joints, that is the knee, the foot, the ankle, the elbow, the wrist, and hand. These areas do not refer pain any appreciable distance. Now, a referred pain is a pain that is felt at a place other than its source. It's felt somewhere else. You can have an injury in your neck, and you could only feel pain 7 inches away at the base of your scapula. I wonder if any of you, I'm going to ask you that question, have any of you in the audience, just you're going to type into your question box, have any of you ever had pain in your scapular region, or had clients that had pain in the scapular region? Why don't you type yes or no into your question box, so we will know if you've seen those. In my country here, probably every other person has such a pain. And I remember when I was in my 20s, I began to get this kind of pain, and thankfully found Dr. Ongley, who could help me with this. I've got a lot of yeses, no no's, a lot of yeses. Okay. So pain felt only in the arm is caused by injury also to a shoulder tendon, not just to the neck. You can have a pain down this distribution of C5 with an injury into the shoulder, because those are C5 structures in the dermatome region. And you could also have it coming from the neck, from, say, C6 or a C7 or a C8. There's a C8 region in the neck as well, just below the C7 vertebra. Pain felt at the medial border of the scapula is often caused by a sprained ligament, and that ligament is usually this one right here, the intertransverse ligament at C7, causes a pain that kind of goes, looks like a banana here, or it could just be one little spot like a penny or a quarter. I don't know, you don't have quarters, but just like a penny. And this is a very, very common problem that people have no idea. You can give a person a massage down here. It doesn't do anything except distract for half an hour, and then it's back again. So I live near a train here, so wait for that to go by. All right. Now, pain in the outer calf is often caused by a micro tear in the gluteus medius muscle of the buttock. I remember I had this once, and I had a pain down in my calf, and I could not believe it. Even though I knew it in my head, I could not believe this pain in my calf was coming from my gluteus muscle. And I remember I went to see Dr. Ongley, and I said, well, isn't something down here also? He said, shut up and lie down. And he injected me with xylocaine. The pain was instantly gone. And then he treated it, and it was gone, very quickly. But I had had it, a crippling kind of pain in the outer lower leg for weeks before I could get to see him. So an in-depth understanding of referred pain is critical for pinpointing the exact location of an injury. So I want you to keep these 4 principles in mind, and these are the principles developed by Dr. Syriacs around referred pain in orthopedic medicine. Referred pain from soft tissue injuries is usually felt distally out toward the periphery of the body. For example, the pain may be referred from the neck or the shoulder down to the wrist, but not from the elbow or the wrist up to the neck. So it goes down and out from the midline of the body. Principle 2, pain does not refer from the left side of the body to the right side. It doesn't cross the midline in this system of thought. If a client experiences a pain in the right shoulder, and then it seems to travel in the left shoulder, and they say, well, sometimes in my right shoulder, and then it travels over there and it goes to the left shoulder. What do you think that means? Well, I'm asking you that as a real question. If you could answer, lots of times people say, well, I've got a pain in my neck on the left here, and then it sometimes on the right, and then it goes over to the left shoulder, and then it sometimes is on the right shoulder, not on the left shoulder. What do you think that means? What's actually happening to the person that lets you know what's going on? Now, if you don't understand referred pain, you don't really know what's going on. You think it does travel. As a matter of fact, when I was young and didn't know much and thought I knew a lot in my early 20s, I thought the pain traveled. I called it traveling pain. It was not true. What it actually means, as some of you are typing in here, is that it means that you actually have two injuries. So for instance, if you have an injury in the right shoulder and it hurts, well, what do? You used your left shoulder maybe a lot more than you would, and then you get an injury there, and then you stop using that, etc. Or you sleep funny and your left side of your neck gets strained, and you have injuries on both sides, but sometimes one is not active and sometimes the other one is active. And so this traveling pain doesn't happen that way. It just means you have a couple of injuries and you're feeling one at one time and another at another time. So let's go on to principle 3. The distance a pain refers is directly proportional to the severity of the injury. So a mild injury may refer pain kind of to the bottom of the deltoid, let's say over here, and while a severe injury can refer pain from the shoulder all the way down to the wrist. And if you have a neck injury, it can go all the way into the hand. Injuries to the shoulder do not refer pain into the hand. They only go as far as the wrist. And injuries to the neck, they go into the hands and the fingers. And knowing that really helps when you're trying to figure out what's going on. And principle 4. An injured structure will refer pain only to other areas within the same dermatome. And this because various structures in the same dermatome can cause very similar referred pain patterns. Now, what's a dermatome? The dermatome are tissues that arose from the same segment in our embryological development. For example, pain referred to the arm from the shoulder is usually in the C5 dermatome distribution, as you see over here. Okay. Another may be cause damage to the rotator cuff, the shoulder joint, bursa in the shoulder. All of them will be C5 structures. And the parts of the shoulder that are in other dermatomes are going to cause a different referred pain pattern. So for example, your heart is made of a particular dermatome that also went down the arm. So when people are getting a heart attack, they often don't even have much pain in the chest. They got pain down their left arm because it's actually made of the same cloth, so to speak. Now this is really counterintuitive to comprehend, especially if it's happening to you, as I spoke of before. And we are not a very good judge of our own referred pain patterns. I remember I thought of another instance that I was going to talk about in the previous myth, and that is this pain in the neck by the whiplash. I had two clients who were in a car, a husband and wife. They were in a car, both got in the same accident, and the husband had 2 treatments and was completely better, and the wife took 6 months and maybe 20 treatments to get better. So even though people have the same problem, it doesn't mean they're going to heal at the same rate. So that's it for my principles, and if you guys have any questions, I'll be happy to answer them. So you can just type them into your question box. Jeff will relay them to me, and or I'll see them, and I'll try to answer whatever questions you have about the things I spoke about or anything else as well. Jeff, you got any questions there?
Yes, certainly do.
Unmute yourself. Okay.
There, am I on? Are you there, Ben?
Yeah, I'm here. I'm here.
Okay, the first one is,
it
says, what percentage of injuries are ligaments versus tendon versus muscle versus nerve in whiplash injuries?
Well, I'd say the overwhelming majority of long-term chronic injuries are definitely in the ligaments. I would say the largest amount of injuries is in the muscles, but they heal usually within a week or two. You know, you're really sore for a week or two, and then that part goes away. But the ligaments, they stay for years often. And a nerve root compression, I would say, is a very small percentage, you know, less than 5%. Next question.
I guess that's active range of motion.
Jeff, you can stay on. You don't have to mute yourself for this one.
Okay.
Say that again.
Active range of motion is the least reliable. Please explain. I guess that's of
Okay,
the
so we said
orthopedic
that before.
tests.
Maybe that person came in late. When you do a resisted test, so for example, if you right now made a fist on your right hand and push down on your leg, okay, what you're doing is you're pushing, but you're not moving anywhere. You're testing your triceps. Uh, Now, if you do a passive motion and you lift your elbow into the air and you push your elbow back, you're doing a passive test and you're stretching the triceps. But if you lift your arm up and you hold it there and then you move it forward, you're using your triceps and you're also maybe stretching it by bringing it back. So you don't know which structures you're dealing with. So because when you do an active movement, you lift your arm using everything. You're using your muscles, your bursa's moving, you're using your joint, using your tendons. So you don't really know what's happening. You just know the person has trouble lifting their arm. So I hope that makes it clearer for you. Next question, Jeff.
Why is ligament laxity so bad?
Well, your ligaments are meant to hold things tightly in place. Let's say I went over to your door to your office or your home, and I unscrewed the screws just a little bit, maybe a ½ inch. I unscrewed the screw. And then you started moving the door, opening and closing the door. What would happen to that door? It would rock around, it would break the screws, it would fall off. Certain things in our body need to be relaxed and loose, those are muscles, and certain things need to be very tight, those are ligaments that hold the bones in place so that we don't move in certain directions. So if you've got loose ligaments in your knee, you have a great tendency to sprain everything in your knee. If you have loose ligaments in your neck or your back, you'll tend to hurt yourself in your neck and your back. You want those to be tight, and when we're young, usually they are. And as we get older, we could get injured or we have an accident, etc., and we get looseness in the ligaments, and that's when many, many injuries begin. People who have loose ligaments get tremendous number of injuries. Gymnasts retire at a very young age, usually with lots and lots of pain and lots of injuries. Next question.
One from Tracy. What can you do if sleeping exacerbates a client's neck pain?
Great question. You can't ask them not to sleep. Usually what happens if the neck pain comes in sleep is that the person is getting into a position that's hurting them. For example, anybody ever wake up and you can't turn your head from right to left? Or have a client who did that? What happens is you get into a position that hurts your neck. So for example, you lie on your stomach, you turn your head all the way. Now if you get over the age of 25 and you do that, you're often distending and injuring your ligaments. If you're very young, probably it's not a bad thing. But I know I can't lie on my stomach with my head turned to the side for too long because it's going to pull on my ligaments. You lose range of motion. So you could also be sleeping on a pillow that's the wrong size. So people go on vacation and often come back with a neck pain, or go to visit a friend and wake up with a neck pain because the pillow is the wrong size. Usually people find the size pillow that makes them comfortable. And if they have the right pillow and they're on this side, that's good. And they usually don't have pain. So if a person has that issue, then either suggesting they lie on their side with the right size pillow that you can experiment with some towels in your office, or you ask them to try and sleep and learn how to sleep on their back. Now for those people who have pain while sleeping on their back, now that's another issue. They usually have pain in every position, and so sometimes buying a lounge chair that kind of goes back a little bit, so they're in a half lying, half sitting position is the only position that they can sleep in. And this is one case where medication sometimes is a good idea so they can get sleep, because if you can't sleep, you can't heal, and it's not terrific. So I hope that answers you. Next question.
What is your initial treatment with spasms in the neck?
Great question. So first thing is I've got to find out what is causing the spasm in the neck. Now spasm in the neck is not a diagnosis. It doesn't tell you anything except something is going on in the neck that's causing the muscles to spasm. And generally what it is you have a ligament tear. You have a sprained ligament, and when you go into a position that your body doesn't like, that tears the ligament further, your neck muscles will spasm. Usually they don't spasm all the time, or else you'd be in the hospital on many drugs because you'd be out of your head with pain. Usually what happens is you move into a certain position and it causes a severe contraction or a spasm to tell you, hey, John, Mary, Joseph, do not do that movement because I'm gonna hurt you. So I'm gonna spasm your neck to get you out of that position. So the first thing you do is you figure out through a series of assessment tests, about 30 or 40 of them, what is going on. The person could have two things they could have that are most likely, either a pinched nerve in the neck, a compressed nerve, or a ligament sprain. And generally it's a ligament sprain. So the first thing I would do with a spasm is I'm going to identify which level. There are 18 different ligaments in the neck that you could sprain, that you can reach with your fingers. The supraspinous ones and the intertransverse ligaments. And you identify, let's say, that C5, C6 and in the supraspinous, and the intertransverse, let's say it's C3, C4, C5. So you work on those. You have to remove the scar tissue, and this is actually the work that I developed. When Dr. Syriacs taught me, I learned how to work on the knee and the ankle and the shoulder, but he said just manipulation and injection, etc., for the neck and traction. And what I did was I applied what he taught me on the other parts of the body, this friction therapy that breaks up scar tissue, to the cervical spine, the mid-back, and the lower back, and the sacrum. And that's what I've been teaching for almost 30 years now to people all around the globe that learn how to identify which ligaments are injured and how you get that scar tissue to be eliminated. You can actually rub it away with this treatment that Syriacs developed and I applied to the neck and back. And so once you figure out what's causing the pain, you get rid of the scar tissue, then the spasm goes away. If anybody comes and says, I have a neck spasm and that's the diagnosis I got from the doctor, it just meant that doctor didn't really know much about musculoskeletal pain and what's the cause. Spasm is what we call a secondary phenomenon. It's just a signal that something else is wrong. So hopefully I hope I answered that question for you. Any other questions?
There's one from Byron. It just says 30 to 40 neck assessments, exclamation mark, exclamation mark, exclamation mark.
Okay. Well, if you come to my
really
workshop in 1 hour, you will learn all of the neck assessment tests. They're not very difficult, and they don't take a lot of time. As a matter of fact, for me, it takes about 90 seconds for me to do all of these tests. You have to test the ligaments, the muscles, then the nerves, the reflexes, and it just happens very swiftly. It's like when you're typing on your computer. If you didn't know how to do it and you had to type a letter, it might take you an hour. But if you really knew how to type really fast, which you probably do, it would take you a minute. So we take about an hour in the workshop, an hour and a quarter, and we teach you all of these things, and you practice and practice and practice them. And for those of you who are living somewhere far away, maybe Melbourne or wherever, I've got a whole DVD program that teaches you everything. Might take you 25 or 30 hours to do, but it's got about 7 hours of tape that we made years ago for people who can't get to us live. If you get to us live, that's a whole lot better, because I can correct you, help you, have you put your hands over mine, etc. And it's fairly easy and fun. In the shoulder there are 12 tests, in the low back there are 26, in the neck there are about 40. But they happen very, very swiftly. You'll see if you come. Any other questions?
There's one from Sue here. If a client is an unstable diabetic, does it affect the healing of ligament?
No, if they're having their proper insulin, it should be completely fine. I've treated many diabetics who've got better. The only thing you have to be careful of when you're working with a diabetic is if you're working with the distal parts of the body, the hands or the feet, the legs, you have to be careful with their use of ice because they don't have a lot of feeling down there in the peripheral parts of their body, so you don't usually recommend ice for a person who's a diabetic or those who have Raynaud's disease, which is a circulatory disease, because they could have some serious problems from use of ice. But otherwise, this treatment is totally safe. Matter of fact, you're much safer if you know how to do the assessment and the treatment, and you know who you can help and who you can't help. Sometimes I have some of my greatest referral clients are people I've only seen once, because I've told them I can't help them, but I know who can, because I know what's wrong with them. And then they keep sending me people for the years and years and years, because I didn't just try and fail. I knew I could not help them, and I knew who could. Maybe one more question, and then we'll probably wrap it up.
Karen asks, how does active isolated stretching help things like Parkinson's disease?
Great question. This is something, I am a born skeptic. I do not believe in things unless I see them. I'm a very concrete person who likes to have things proved to him. And I've heard lots of stories about, okay, this kind of work, that kind of body work, that kind of vitamin helps with Parkinson's or MS or polio or that kind of thing. And I thought always it was a lot of bunk. So when I was trained by Aaron Mattis, I heard these stories and stuff like that. Not that I think anybody's lying, but I have to see it with my own eyes. So I decided that I would try it out and I would see if it worked. And I treated two people, one person who had MS first and another person with Parkinson's. And I told the person, I have no idea if this is going to help you. Supposedly it does, but I'm a little skeptical, but let's give it a try. And I gave the person a discounted fee rate because I just wanted to experiment on this MS person who I had known for many years in a wheelchair. And I worked with her 4 times for an hour and a half each time. And she came back to me with tears in her eyes around the 4th time and said, Ben, I cannot believe what's happening here. That she was able to, now it may not sound like a lot to you, she was able to turn over in bed and she was able to crawl, which she hadn't been able to do in years and years from the work we had done. And then I worked with a professor who had Parkinson's disease, who couldn't write, because most people with Parkinson's can't write. They write teeny letters and you can't see it. They often have pain in their body. They can't sleep through the night. This person couldn't sleep. She couldn't lift her right arm. She dragged her right foot. And so when I worked with her over a couple of months, all of those symptoms disappeared, and it blew my mind, actually. So then I started to investigate what is really happening here, which is getting back to your question. So what AAS does is it builds new neurological connections. It does something called neurogenesis. And we know from the research that's been happening over the past 20 years that the brain continually builds new connections. And sometimes if you lose a function in one side of the brain, one part of the brain, it will recruit other parts of the brain to do the same job. So I think what's happening is we're building, by this repetitive work that we do over and over and over again, very gentle stretching and strengthening work, that it builds new neurological connections. Now, I cannot explain it any other way. Why would this person who had no ability to lift her right arm, couldn't sleep, couldn't write, she was writing on the blackboard within 2 months. She was combing her hair with her right hand. The person who had MS, after about a year of treatment, began to be able to stand, not walk around like you and I, but just standing was like a big deal with a walker and be able to move around. So I've seen this with my own eyes. I believe it. Don't believe me. If you want, you can take the workshop. I'm going to do another workshop after the neck one on AIS, on the active isolated stretching. It's a phenomenal technique that helps people who are healthy, helps people that have various neurological conditions, helps people who are injured get better quicker. I make it a part of all of my different works that I do with people that is appropriate, which is most people. So, hope that answered that question. And some of you might not be aware that I have lots of different webinar series on demand on my website, benbenjamin.com. You can order these in a recorded form. We've got some by Tom Myers, fantastic ones by Tracy Walton on cancer, hospital-based massage, pregnancy massage with Carol Osborne, Whitney Lowe, another well-known person in the United States on orthopedic massage, has a different approach to mine, excellent approach. So if you like webinars, and especially if you live far away, there are tons of them on my website, benbenjamin.com. So I hope you've enjoyed this workshop on the web, and I hope to see many of you at our workshop on March, 13th, I think it is, 14th?
14th, yes.
On the 14th. So if you're interested, get in touch with Jeff. He'll tell you about it now. And it was lovely to have this webinar with you. Back over to you, Jeff.
All right, thanks, Ben. Sorry to Shari, Scott, Mark, Lindsay, and Brett. I'm afraid we can't get to your questions today. But nevertheless, just before I officially thank Ben.
Actually, Jeff, if they want to email me at Dr. Ben, drben@benbenjamin.com. I'll be happy to answer it in an email. That's drben@benbenjamin.com. Or they can just go to the website and click an email to me.
All
So
right,
we'll get
no
to their
problem.
question too.
All right,
Okay,
cool.
great.
Thank you. So, yeah, we're about 28 days away from Ben starting his workshops here. So it's great to see what we're actually going to be learning and hopefully mastering those assessment and treatment techniques. I really can't wait to experience the AIS. If you head over to the benbenjamin.com.au website, we'll keep the early bird rate for you guys. So to give you a bit of an advantage for having the foresight for being on the call. So just a bit of a bonus here. That will save you $100. So if we get that, in the next before noon tomorrow, get your registration in there. So with that, I'd like to wrap the 5 common myths of neck and back pain webinar. Thank you all for attending, and a special thanks to Dr. Ben Benjamin for preparing and presenting this fascinating webinar at 4 o'clock in the morning. US time. So thanks for getting up and presenting for us, Ben.
Okay, I'm wide awake.
I'm sure. Thank you so much.
You're welcome. Look forward to seeing you in Australia. Bye-bye.
Bye bye.